Lunchtime Chat with Sandy. The first thing I'd like to say is that this program does not contain coarse language and is definitely appropriate for all audiences. Audio discretion is not advised. Just saying. Don't panic. Okay. The other thing I want to say is that when I chose this topic for this month, I didn't realize how close we are now to Valentine's Day, so that was just a happenstance. So just go with it. You never know. You might learn something today that will enhance your Valentine's Day and make it more interesting and fun for you. Okay. So, hello everyone, and those of you across the country as well as those in the Greater Toronto Area, etc. Welcome to Sex with Sandy. Oh gosh, did I say that out loud for today's chat? I thought Parkinson's and sexual issues sounded a bit boring, but Sex with Sandy swings the pendulum too far in the other direction. Makes it sound like this topic is of little importance and maybe trivial. This, however, couldn't be further from the truth. So how about let's talk about sex and Parkinson's. It works for me. Sure hope it's okay with you as well. The words intimacy and sexuality are often used synonymously, but I think of them as different aspects of interactions of the sexes. Intimacy is an important aspect of human behavior that involves communication, physical and emotional closeness, and interpersonal interaction. Sexuality is a manifestation or demonstration of intimacy, which is influenced by many factors, including culture, psychological and social aspects, to name just a few, and contains the basic need for human affection, love, touch, and intimacy. So today I'm going to focus on sexual dysfunction, which is a problem that affects a person's health, as well as their emotional and physical well-being. Make no mistake, however, many couples struggle with sexual problems, not just folks with Parkinson's. Sad to say that while sexuality is often the origin for happiness and satisfaction in a relationship, sexual dysfunction, on the other hand, often causes frustration, suffering, and a poor quality of life. Yet it still remains a taboo topic that most people are too embarrassed to talk about. As a result, the problems remain untreated and unresolved. What I'm hoping to accomplish today by addressing some of the most common issues impacting sexual function is to help you to understand that you are not alone and to realize how important sexuality and intimacy are to a person's life, whether or not you are sexually active or in a relationship. Before I go any further, there are a few things I definitely want to stress. 1. Having Parkinson's does not automatically mean that sexual difficulties are inevitable. Just because I am discussing this today does not mean it will be a problem for you. If you have no concerns about this, then, as the saying goes, stay calm and carry on. Remember that no two people are alike. If you are happy just to be close to one another, or happy to have sex once a month, then you don't have a sexual problem. If a full and frequent sex life is an important part of your relationship, Parkinson's does not need to prevent this, although, in all honesty, some adjustments may need to be made. My comments today are intended for those of you who are single, as well as those who have Parkinson's and have spouses or partners. It is important to note that healthy sexuality and intimacy is something that is desired between partners. Unwanted sexual contact, even between spouses, is rape. I will be speaking to 2 specific points later where unwanted sexual contact may be present and need to be discussed. And these issues are regained sexual function and impulse control disorder. Let's go back a moment to intimacy, because to me, intimacy is the cornerstone of relationships. We all have physical needs for closeness with people we care about, but it doesn't have to be sexual. After all, one of the first things we learned to do when we were children was how to give hugs, a gesture that we've all passed on to our children and to our grandchildren. I don't know where hugging originated, but what I do know is that it is a widely accepted gesture that says so many things like, "I'm so glad to see you. Thank you so much. Congratulations. I'm sorry for your loss." And in so many cases, a hug just says, "I love you." The hugs and kisses symbols of X's and O's accompanies our signature throughout our lives, on our cards and our emails to friends, and everyone automatically knows what it means. As many of you know, hugs are an important part of my life. In fact, many years ago, a person with Parkinson's paid me the highest compliment when they said, "Sandy, you're just a hug waiting to happen." Very early on in my tenure here, I realized that for people with Parkinson's, the ability to do something like giving and receiving a hug can be a very difficult task. I came across an article written by a lady in the United Kingdom who has had Parkinson's for many years and does a much better job of explaining what I'm talking about than I could ever do. So I'm going to share it with you now. It's called Cuddles and Parkinson's. Cuddles and Parkinson's sounds a bit like a theatrical double act. It is not. It describes 2 physical conditions that don't comfortably exist together. In fact, the art of cuddling and the state of Parkinson's can seem totally incompatible. A cuddle is defined as an effortless, smooth, responsive gesture of affection given to someone you care about. Parkinson's, on the other hand, is an exhausting, uncoordinated, constrained state of being. With Parkinson's, the hug or cuddle, a once natural and spontaneous action, is sometimes no more. Physical expression is limited when you don't have freedom of movement. Even a thank you hug for one's partner at the end of the day requires careful cooperation. When basic energies are exhausted by the intricacies of balance and ensuring that your body is all going in the same direction at the same time, there can be little energy for physical affection. When something as simple as when to hold hands or when to put an arm around one's partner's shoulders involves planning every stage of the way is now a complicated maneuver, then how much easier is it not to bother at all? When the simplest move is slow, clumsy, and uncontrollable, it seems more dignified not to even try. Indeed, an attempted hug can end up looking like some kind of a feeble assault or even slapstick comedy when, leaning forward to bestow an affectionate peck or kiss, one ends up spread-eagled in a heap as a result of shaky balance. Truly, pride goes before a fall and self-esteem suffers too. It is difficult to show love when one feels unlovely. Everybody needs to feel attractive somehow. And with Parkinson's, with or without the side effect of medication, it can seem a cruel travesty of grace. But people with Parkinson's, please think about this really carefully. Yes, it is true that with Parkinson's, the body and limbs are uncomfortable and move with all the grace of lead weights. Also, responsive gestures of affections, such as the hug and gentle touch, may be difficult or sometimes even impossible to give. But please don't deny the opportunity for receiving such approach. Eventually, the discouragement of such compliments, for that is what these approaches are, will only serve to strengthen the belief in one's own unloveliness. And people with Parkinson's, please think about your spouse, partner, your friends. They may feel at a loss to help you or to make you feel better about yourself, especially when faced with the unpredictable responses you may be having to your medication. The giving or showing of affections may at times be the only form of reassurance your loved ones can think of. If you react negatively to their gestures because you can't always respond and hug them back when you want to, just think how helpless your partner will feel when their reassurance is rebuffed and rejected all the time. Some people with Parkinson's try to limit all activities to the times when your medications have produced its best results. But think honestly how much more reassuring it must be to receive gestures of affection when one is at one's worst. It is easy to feel lovable at one's best, but it is so much better to feel loved at one's worst. By now, I'm sure you can see where I'm going with all this. If the lack of coordinated, spontaneous, controlled muscle movement, also known as Parkinson's, makes giving hugs a challenge, then what about all the havoc these same movements play when individuals with Parkinson's attempt to engage in a very intimate relation with a partner? The words sexuality and intimacy often make people blush or utter a childish giggle, and yet most people feel they are a very important part of their relationship. So before we start talking about some of the challenges you may be facing, I think it's important to establish what we mean by the words sexual problems. Even in the most successful long-term relationships, where health is not a factor, couples admit that there are times when both individually as well as together, their sex life is not perfect and does not always meet their needs. I do not think that these couples would feel that they have sexual problems. The dictionary definition of sexuality and intimacy is the capacity for physical attraction or intimate physical contact between individuals. If you went to the local shopping center and did a survey of what sexuality and intimacy means to people, the answer would be a complete spectrum of both activities and feelings. Therefore, what is the norm? The norm is whatever you want it to be, or, more importantly, what you allow it to be. Before I go on, I would like all of you to ask yourself a question. Do I live with Parkinson's, or does Parkinson's live with me? The words are the same, but the meaning is completely different and plays an important role when it comes to dealing with the challenges of intimacy. As I said a few minutes ago, it is important to remember that having any physical problem, including Parkinson's, does not mean that sexual difficulties are inevitable. It could mean very well that you're happy to just be close to each other. It could mean that you're happy to have sex once a month, or a week, or a day. What I'm trying to say is that there's no such thing as normal when it comes to consensual sex. Something is only a problem if it is a source of discomfort, worry, or stress to one or both partners in the relationship. The key to dealing with any problem in a relationship is a four-letter word, ending in K, and meaning intercourse. Yes, you guessed it. Talk. T-A-L-K. Now, you really didn't think I was going to use another four-letter word, did you? If you did, shame on you. Work, family pressures, and embarrassment are just a few of the factors involved in the breakdown in communication about sex. If your sex life was not satisfactory before diagnosis, it will not improve without help when you have to adjust to a chronic illness. Intimacy in loving couples is often impacted in a negative way also. After all, you're now sharing your lives and your beds with an uninvited and unwelcome extra partner called Parkinson. Just like all other aspects of your lives, living with Parkinson's means adaptation and adjustment, even in the bedroom. The effect of Parkinson's on a couple's sexual relationship has historically received very little attention from medical professionals. As a result, data about intimacy, sexuality, and Parkinson's is thin on the ground. When was the last time a doctor asked you about your sex life? The fact that this area of your lives has been ignored by your medical team might give you the impression that it's not important, or that you're the only ones who are experiencing difficulties. Again, nothing could be further from the truth. The truth is that many healthcare professionals are uncomfortable discussing sex, and even if they did ask you about your sex life, they wouldn't have a clue what to suggest if you indicate you're having a problem. So therefore, it's easier for them not to ask. Here are some arguments that are neither accurate, certainly not justified, but were in the past accepted by the medical community, believe it or not, as reasons why they don't have to discuss sex with their patients. 1. People with Parkinson's are old. Old people are not interested in sex. Therefore, people with Parkinson's are not interested in sex. 2. People with Parkinson's are disabled. Disabled people are not interested in having sex. Therefore, people with Parkinson's are not interested in sex. Therefore, if there is no interest in having sex, they're not having sex. So, it's not a problem. Makes it easy for doctors if they think this way. If the public response to both Viagra and Cialis is any indication, we can safely assume that sexuality and intimacy is a concern of most people, regardless of age. More than just the physical act of intercourse, sexuality is love, warmth, sharing, and touching between people, and has a significant role in the promotion of total health. Just like with all other aspects of Parkinson's, the possible causes of sexual dysfunction will vary from person to person. Much depends on the state of a couple's emotional and physical relationship before Parkinson's. That is, before Parkinson's became part of your lives. If your relationship has been happy and healthy, there's no reason why it shouldn't continue that way, albeit with some adjustments. Anger, anxiety, and grief are common and are not conducive to sustaining intimate relationships, and certainly not conducive to rewarding sex. Anxiety can interfere with how your drugs work and can also increase the severity of your symptoms. Tremor and dyskinesia are both increased by anxiety, as are the times when your medications are not working and you are in an off state. Anxiety about your performance can be infectious, and if your partner picks this up, it can definitely make things worse between you. Another factor, fatigue, whether the drugs are working reliably, and the motor symptoms such as stiffness and slowness of movement are all very important factors for determining the quality of orgasm in both sexes. Orgasms may be weaker or less intense under these conditions. Difficulties may occur in couples who don't try or are unwilling to make changes in their sexual patterns. For many people, their motor functions are best in the morning and worst at night. So, if you're accustomed to being intimate and having relations at night, you may want to rethink the timing and give yourselves the best chance for things to go as smoothly as possible. Also, if things like nightmare and acting out dreams are disruptive at night, and you decide to sleep in different beds or different bedrooms, you need to make sure that you find opportunities for spontaneous sexual contact in other ways, as desire is still very much present. Therefore, it's important to be creative and enjoy it whatever time suits you both. In men, there may be difficulties achieving an erection, or premature ejaculation may result. There is also a tendency to hurry intercourse due to anxiety about being able to sustain an erection, but this can be counterproductive because it may leave your partner feeling deprived of the pleasures of foreplay, and she may feel used. On the other hand, sometimes the ejaculation takes so long that the erection fails through fatigue before ejaculation can take place at all. If you're a man with Parkinson's, there are certainly ways to enhance erectile dysfunction, including things like Viagra, Cialis, injectable medications, vacuum devices, and prosthesis. But there are a few things to keep in mind. Before you ask for a referral to a urologist or a sexual medicine counselor, you should seek counseling as a couple. You need to make sure that if you are restored to sexual health, i.e., able to get an erection, that your partner is okay with this. I have known some partners who have been distraught at the thought of resumed sexual relations because they're not ready for that. And this can end up being disastrous for both partners. Another reason to talk ahead of time. For many women, with and without Parkinson's, having an orgasm may be difficult. Also, if the woman has gone through or is going through menopause, physical changes due to lack of estrogen may result in a thinning of the walls of the vagina. Entry of the penis can be uncomfortable due to dryness and loss of elasticity. Also, irritation in the urinary tract can occur. Stimulation of the clitoris can begin to hurt rather than excite. Vaginal and bladder infection is more common, making it very difficult for women to want to be sexual. Estrogen replacement was used more frequently in the past than it is today, but it is very important to speak to your doctor, as he or she may suggest something like weekly vaginal estrogen cream. There are several alternative vaginal moisturizers and lubricants available over the counter today as well. Different medications can both improve or interfere with sexuality and intimacy. I'm going to talk about 3 potential situations where medications may impact both negatively and positively. Medication used to treat the symptoms of Parkinson's, especially the dopamine agonists like Mirapex or Requip, to name 2, but sometimes even levodopa as well, may potentially increase the sex drive in a small percentage of people. I have spoken to many individuals who see this as a very positive thing, and indeed, in their case, it definitely is. However, and this is a very important point, the abnormality increased sex drive may also be accompanied by a lack of inhibition or sexual interests that may be completely out of character for the person. This is known as hypersexuality. A person with hypersexual behavior may not realize that their behavior is inappropriate. They may suddenly become promiscuous. They may say sexually inappropriate things in public. These are most ruinous for relationships, and they may not realize that their advances are assuming nightmarish proportions for their spouses. I have spoken to several women who have described the persistent, unwanted, and incomplete attempts by their husbands to achieve satisfaction as having made them feel raped and violated. At the same time, they were embarrassed and ashamed to talk about it. When they understand that the medications contributed to this, they say, "But why didn't somebody tell me?" Or, "You mean I didn't have to put up with it?" If this is happening to you, please, 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 don't keep it a secret. Treatment is available for the person with Parkinson's, and the doctor can discuss practical ways to reduce the consequences of this behavior in order to restore dignity to both of you. Again, I want to emphasize that the person with Parkinson's does not realize their behavior is inappropriate, and when the problem is addressed by the doctor, they are often horrified and ashamed at how they have behaved. Different from hypersexuality is a renewed interest in sex. Many people with Parkinson's encounter unpredictable fluctuations in responses to their medications, which we refer to as being on or off. Reduced physical mobility, that's being off, may impact on someone's level of interest in having sex. This applies to both men and women and can be confusing for the partner. Especially initially when someone has been untreated, anti-Parkinson's medications may seem to increase desire and renew interest in sex like someone once was. This is because the medications are freeing someone to act upon sexual feelings that they may have been unaware that they still even had. Again, in order to have good sex, your medications need to be working, and it is important to accept the fact that the renewed desire is coming from within the person, not the medications. Properly working anti-Parkinson's medications won't change the way you feel toward your partner, but they can certainly change your ability to be able to express your feelings physically. 2 common non-motor symptoms that many people living with Parkinson's have are depression and anxiety. These symptoms can interfere in the person's interest in sex. While treating depression and anxiety may restore a person's interest in sexuality and intimacy, it's important to be aware that some types of antidepressants, as well as anti-anxiety medications, can either A, reduce a person's interest in sexuality and intimacy, or B, reduce a person's ability to perform sexual activities, or to reduce the ability to orgasm. Men may find that antidepressants and anti-anxiety medications can cause erectile dysfunction. If you find that treatment for depression or anxiety is interfering with your sex life, speak to your doctor. There may be a different type of medication you could be switched to with less side effects, or the doctor may suggest something to help with erectile dysfunction, like Viagra, for example. One final note of caution: if your doctor recommends Viagra, please be aware that it can lower your blood pressure. And if you are an individual for whom low blood pressure naturally, or the symptom of orthostatic hypotension, that's when your blood pressure drops to your boots when you change positions from lying to sitting or from sitting to standing, please be aware that Viagra can exacerbate those symptoms, and you need to be aware of that. Fatigue plays a huge role in the disruption of sexual relationships and intimacy, whether or not you have a chronic illness. In Parkinson's, fatigue is due to the fact that everyday tasks take much longer and require much more conscious effort to perform. In many individuals, sleep can be disturbed, and the drugs tend to lower your blood pressure, which can make you feel tired, and sometimes tired most of the time. Both of you may be sleep deprived. So again, as I mentioned earlier, you need to be creative in how you choose your time and your place for sex, not at the end of a busy day. Unplug the phone and enjoy some privacy at whatever time suits you both. Try setting the alarm a little bit earlier in the morning so you can enjoy some uninterrupted private time. If your muscles aren't moving well when you wake up, take your first dose of medication while you are lying together, just sharing some warmth and intimacy while you are waiting for the medications to kick in. It is really complicated for those of you who are Parkinson's partners. Both men and women feel that with the rigidity and slowness of movement of their loved one, it is as though they have to get used to somebody new in bed with them. They have been used to cuddling and throwing their arm over someone for years, very spontaneously. And suddenly, that body feels different. There is also the issue of having sex with someone when they are sick, or having sex with someone you are caring for. Then it may also feel that there's a nurse-patient relationship or a parent-child issue. Changed dynamics and role reversal within couples also affects sexual function. There may be feelings of resentment, hostility, loss, and powerlessness. There's another issue for both men and women who can't perform the way they used to, or the way they think their partner wants them to. Not only does the person with Parkinson's miss their own sex life, they feel they're letting their partners down. Changes in body image, tremor, dyskinesia, lack of facial expressions, skin texture, and even smell. Drugs may cause changes in body odor. It may make people feel of either sex seem less attractive to their partners at the very time when their self-esteem is crumbling around them. Sometimes difficulties arise, when one partner wants more than the other can give. So often within a relationship, the refusal of sexual advances causes enormous hurt to the person being rebuffed. I have spent time discussing some of the physical complications that can have a big effect on your ability to have satisfactory sexual intercourse. But it is very important to capitalize on sexual and intimate touching that does not involve sexual intercourse. That is why I talked previously about the other kind of intercourse, talking. It is important to communicate your needs so that your partner understands how you are feeling, so that you can both find solutions together. We have covered a lot of ground regarding intimacy and sexuality in a very short time. So here's a quick review. First of all, there are things you can do to cope with possible reduced sexual feeling and function. However, always see your doctor if you're concerned about your medical condition, your treatment, or your sexual issues. The slowness of movement, tremor, and rigidity may interfere with the practicalities of lovemaking. Men can have problems with getting and/or keeping an erection. This is impotence. Men may be unable to ejaculate. Women may experience vaginal dryness. Reaching orgasm may be difficult, regardless of gender. Medication can diminish sexual desire and reduce sexual response, and it can also cause hypersexuality as a medication side effect. Hypersexuality is a compulsive drive to have sex frequently or in a way that is out of character. This is due to medications used to treat Parkinson's. It can and should be treated by a doctor. For a person with Parkinson's, factors potentially impacting sex include negative body image, reduced self-esteem, depression and grief, anger and stress, disease-related fatigue. For a partner of a person with Parkinson's, issues may include feelings associated with their loved one's diagnosis, including fear, anxiety, depression, and grief. There are coping difficulties for the partner of people with Parkinson's. Tiredness from taking on additional responsibilities, loss of sexual interest in their partner because of Parkinson's symptoms such as involuntary movements or change in physical appearance, changed role from partner to caregiver. Issues impacting the sexual dynamics for the couple may include a person with Parkinson's may have reduced mobility, which may force them to take a more passive role in lovemaking than he or she used to. A couple may have firmly established roles in their relationship, and the sudden unfamiliarity with each other due to Parkinson's symptoms, as well as changing their roles, can stall aspects of the relationship, including sex. Symptoms of Parkinson's may be worse at night, prompting couples to sleep in separate bedrooms, which reduces opportunities for spontaneous sex. The way each person handles the diagnosis and daily demands of Parkinson's may cause conflict. Communication problems can spill over into the bedroom. Parkinson's can disrupt a couple's lovemaking routine in many ways. Further problems will arise if the couple is unable or unwilling to make changes to their sexual attitudes and habits. Every couple affected by Parkinson's has a different experience. Generally speaking, you could try to learn more about the potential impact that Parkinson's and treatment may have on sexuality. Appreciate and recognize the emotional stress you're both going through, even if you are together in non-sexual ways. Talk frankly and openly about your sexual needs. Communication is really the best remedy for all types of relationship problems. Experiment with different routines. For example, switch your lovemaking to the morning when symptoms are less pronounced, or when you have better mobility, i.e., during your on time. Place the emphasis on different physical expressions of lovemaking, for example, on foreplay, touching, and kissing, rather than penetration. Explore and practice different physical, comfortable positions for successful and pleasurable penetration. Adopt new sexual roles according to you and your partner's abilities. Find new solutions for physical stimulation, that is touch, arousal, and orgasm. Work together with medical staff to reduce the effects of medications on sexual functions. Professional help is available. Asking for help is a sign of strength, not weakness. Your family doctor may be open to discussing this with you. So should your neurologist be. You may need a referral to a urologist, a gynecologist, a physiotherapist, a counselor trained in sexual therapy, a counselor who is trained in couples therapy. Ask your doctor for information, advice, and referral on any type of sexual difficulty. If talking and communicating with your partner is difficult, counseling for the two of you may help. Your doctor may be able to refer you to an appropriate service. Sexual dysfunction can be medically treated. For example, certain prescription drugs can stimulate an erection, while estrogen medications or water-soluble lubricants can ease vaginal dryness. Regular exercise reduces fatigue by increasing fitness and stamina. If you're not exercising already, see your doctor for guidelines on appropriate activities. Some studies have found that depression impacts more on the person living with Parkinson's than even their physical symptoms do. Talk to your doctor about treatment options for depression if you feel that you are experiencing this. I'm now going to read you something that was written by a person with Parkinson's, which really spoke to me and I think rather sums up what I have been trying to get across to you today. Within the relationship of marriage, the essence of sexuality changes. The questions arise within ourselves of our mate's desire within the scope of our physical appearance. Of course, we are the same person, but love and desire sometimes take separate paths. The concept we hold of ourselves becomes different. Feelings of self-worth, of acceptance, become clouded by our disability. This is when love must change. It must become wider than before, more willing to accept the faults, the failures, and the physical appearances. Either accept or fade away, to become just another memory. Lovemaking either comes from the desires of closeness, caring, and deep-bound love, or a desperate attempt to regain a lost past. As often as we try to rise above the physical, we are reminded that we are physical. We cannot deny our existence, physically, spiritually, or sexually. To do so is to admit defeat to our disability, to give up a part of our lives and let part of ourselves die. I am blessed to have a care partner who shares with me the strength of love that allows us to see sexuality beyond the physical. on the porch at sunset, watching the pastels of the day give way to the stars of night, or at 3 in the morning when I scream out in pain from a combination of leg cramps and twisted muscles and tremors. She is there, holding and caring, willing to accept me for who and what I am. When our desires lead to caresses and nowhere else, I know our love is deep enough to find satisfaction, even in a gentle touch. But still, somewhere in my mind are the doubts. Why? What if? Knowing it's going to get worse, I try to see the future. 5, 10 years from now, what will it be like? What if the situation were reversed? What if she had the disability and I became the care partner? Sexuality and Parkinson's is a very sensitive subject for both of us. It hurts to know what the future holds, to see others more progressed than I. This isn't what I had in mind when we got married, when we had our first child, when we bought our first home. It certainly isn't what I pictured for our retirement or our golden pond. When it comes to surveys and statistics, I think it really doesn't matter that I don't have 2.3 orgasms per week arising from 3.4 attempts. Who cares? That is not what my life is all about. At this point in my life, sex and love are the same. They are held together in the eyes of my wife, in a smile, in a soft and warm kiss. How many times have we made love? Once. It began the moment we met and will not end until we each have taken our last breath. I hope that meant as much to you as it did to me. Okay, is the article on Cuddles and Parkinson's available for me to print is a question I have today. And given this month's meeting, the answer is yes, I have that, and I would be happy to make that available. You know how to get me, and let me know who you are and how many copies you would like of that. I'm glad you liked it as well as I did. I had another question before we started today, and that is the sexuality due to the disease or some medication? If medication, which one can increase sexuality or slow it down? I think I have answered those questions. Sexuality issues are due, in some cases, to the disease. Also, they are side effects of some medications. Some medications can make things better, but certainly some medications can interfere with the sexual process. So again, I don't think I can say which one in particular increases sexuality, which one in particular slows it down, as again, it varies for everybody. So if the individual who asked this question would like more information, and if I haven't answered these things appropriately in my comments today, please don't hesitate to either give me a call at 1-800-565-3000, extension 3375, or you can send me an email at sandy.jones@parkinson.ca, or you can send an email to my CEO, debbie.davis@parkinson.ca. So I don't have any more questions for today's discussion. If you want more information about any of the things I've already discussed, please don't hesitate to get in touch with me. And I just want to make one more comment, and that is, I've learned, first of all, more from people with Parkinson's on every aspect of Parkinson's than I've ever learned out of a book. And here's something that I learned from a person with Parkinson's as well. He said to me, I'm not always as good as I once was, but I'm as good once as I ever was. I thought that was quite telling. Anyway, happy Valentine's Day. We'll have a chat in March. And in March, I'm going to talk about partnering with your doctor to get the most out of your Parkinson's, medications, I should say, and to be able to have the most effective conversations with your doctor. So I'll look forward to speaking with you in March. Take care, have a good month, and bye for now.
The leader has turned lecture off and your line has been unmuted.